Hi, everyone. Thank you for joining. So while I know this is the Massachusetts Coalition for Serious Illness Care, we know you are also all from all over the place, which is one of the wonderful things about virtual meetings. So please, if you'd love, put your name, organization, and location in the chat. Even though I know, as I said, it's still virtual, I'm so excited because we just have so many wonderful discussions lined up for today. And of course, this is the first time that we are offering continuing education units for the very first time. We're excited to be offering 1.5 AMA PRA Category 1 credits in joint providership with the Massachusetts Medical Society. These credits can be used by several disciplines, including physicians and nurses. And for all you social workers out there, this program has been approved by the Social Work Continuing Education team at the NASW Massachusetts Chapter 2. Okay. So before we dive in, I want to thank our sponsors. We could not do this work without your support. Huge thanks to all the organizations from Massachusetts, especially Blue Cross Blue Shield of Massachusetts, for providing the core operating support that really gives us the foundation to do everything that we do. Also, thanks to the national foundations who have funded our research over the years. And of course, thanks to all of you who keep showing up. Yay, thank you for being here. We are also thrilled to be officially having Michael Curry, President and CEO of the Mass League of Community Health Centers, join our Leadership Advisory Board. Thank you, Michael, and your team for making the time to engage in and support this work. Okay, so here's a quick peek at the agenda. I'm going to kick us off sharing the story of our first ever strategic plan, remind us a little of where we started, and then share with you our updated vision, mission, and core principles. Then our leadership co-chairs Andrew Dreyfus and Maureen Visignano, along with Michael Curry, will join me to share their reflections on our new direction. And we'll take questions and comments from you, of course. And then I'll be moderating a panel with leaders from a palliative care community health worker program out in California. Then Stephanie Chan, our intrepid coalition deputy director, will give an update on some of our existing projects and collaborations. And we'll close with a panel exploring participatory research models with leaders from the Community Coalition for Equity in Research, which is housed here in Boston at Harvard Catalyst. Okay, chat is on. I can see you're all chatting in there furiously. I appreciate it so much. So, jump in, share comments, questions, reactions as we go. I'll be monitoring it all the time. And for those of you on Twitter, we're live tweeting using the hashtag that's over there somewhere, down below somewhere. You can find it. Okay, so our strategic plan. So other than the early conversations that we started having back in 2015 with the founders, this is really the first time that we've ever stepped back and asked, what have we learned? What's working? Where should we focus? What is the particular role that the coalition itself can play? So over the past 8 months, we've reflected on our research, listened to feedback from coalition members, partners, and other stakeholders, and embarked on an equity-focused strategic planning process with help from the Tammy Dowley-Blackman Group. Out of that process, plan has emerged, which centers the needs and voices of the community, what patients and real people really want and value from their healthcare, and sharpens the coalition's role as a convener to ensure that everyone, especially people living with serious illness, get care that supports what matters most. At our core, we are about improving healthcare for people with serious illness. It's in our DNA, it's in our name, and that is unchanged, but we are shifting, and I want to explain. In 2016, when we all gathered for the first time in a packed to the gills JFK library, we shared our vision and the collective goals that we thought we could all work towards in different ways. Our goals were about proxy completion and discussions with your healthcare agent, serious illness communication training for clinicians, as well as health system kind of documentation skills and interoperability. Since then, we've learned a lot, especially through our research with patients and families. Over the last few years, we've surveyed about 8,000 people in representative surveys, about half national and half Massachusetts. We've also talked to more than 800 people through qualitative research platforms where we've tested concepts and language. And our findings are pretty clear. When you talk to someone about advanced care planning in pretty typical ways, share your goals, values, and preferences in case you can't speak for yourself. Well, that sounds a lot to people like dying. And when it sounds like dying, it sounds like something they're not ready for or they don't want. It was even one of those light bulb moments we had back in 2019 when we realized that even the phrase goals, values, and preferences has started sounding like death to people, which kind of makes sense because possibly the only time they're going to hear that kind of language explicitly is at the start of a difficult conversation about a prognosis that isn't looking good, about treatment that isn't no longer working, about when there's nothing left to do. I mean, think about it. Why is a goals of care conversation shorthand for a DNR or hospice? Don't we have goals of care all the time? Another main finding that we've found through our research over and over again is just that all people, regardless of age, race, ethnicity, ability, health, or diagnoses, all people desperately want to be listened to, heard, believed, have their whole selves recognized, and show up in decisions about their care. And the more we learned from our research, the more we felt the need to challenge ourselves to think boldly and expansively. The health inequities laid bare by COVID really forced us to reject the status quo. So here's our vision. It's our aspiration, a transformed healthcare system that ensures everyone receives care grounded in understanding, empathy, dignity, and respect, because you can't have quality care without it. How do we know that? Because that's what real people kept on telling us over and over again. For example, when we presented people with a slew of different concepts about what their clinicians might say to them, almost everyone gravitated towards this sense of collaboration. We'll figure this out together. This kind of collaboration is, of course, at the heart of shared decision-making, and advanced care planning is a part of shared decision-making. So what our research is really telling us is that the biggest opportunity we have to improve all of these things is to focus first on those core elements that people really want, the relational dimensions of care that are foundational to any kind of meaningful communication. The sense of connection, safety to ask questions, to share what is going on, to have their current needs met, and feel secure in their understanding of what is happening and be included, really included in decisions. And when those conditions are met, then we can let considerations about future care or care when you can't speak for yourself, those can be then a natural extension of the conversations people have been having all along. So as we crystallized our new vision, we also redefined our mission. And here it is. Our mission is to strengthen communication, collaboration, and connection between healthcare systems and communities, between patients and clinicians, to support what matters most to everyone seeking care, especially people with serious illness. This is very much about how we as a coalition, our leaders, our staff, want to focus our time, energy, bandwidth, and attention. And we're refining and focusing even further through what we're calling our core principles. The first core principle is that we want to approach our work through the lens of the needs, experiences, and challenges of people who are socially, racially, culturally, and economically marginalized, people with language barriers, cognitive, intellectual, or physical disabilities, communities of color, and low-income communities. Our research has found time and time again that people who walk into the healthcare system with less privilege face more challenges in getting the connection, communication, and care they need. But the core of those needs is universal, which means that if we redesign healthcare systems to meet the needs of people with less privilege, we will end up improving care for all. The second principle is that we have to start thinking upstream about in different ways. We have to focus on programs, interventions, and solutions that can benefit all people, because there is no magic line that separates a serious illness from everything else. In some ways, this definition of serious illness is starting to work against us more than is for us, because it's creating powerful psychological barriers for patients and families and clinicians thinking we're not there yet. The care that people with serious illness want is the care everyone wants. So we have to focus on bringing those key skills and hallmarks of palliative care for, say, listening, whole person focus, inclusive of family and caregivers, balancing quality of life and mental health to all the care experiences more broadly. Doing this will disproportionately improve the care for people with serious illness. Let me give you a quick example. An exciting new quality measure, Heard and Understood, was created by many of our national colleagues and recently endorsed by the NQF, National Quality Foundation. But it's only defined for people already in outpatient palliative care. Imagine the power of that measure if we asked it of everyone. For starters, we'd probably see how much better people's experiences were if they were getting palliative care, but it also reinforces, if we did this universally, that feeling heard and understood is not only for the very sick, and that these skills are skills that all clinicians should have. So underpinning all this work are our 4 equity principles: to rebalance power, recognize and address power dynamics, to value inclusivity by investing deeply and authentically in relationships, to practice equity as a verb actively in everything we do, and to build common ground around a shared understanding of what it means to center equity. In terms of the what, well, here are our 3 strategic priority areas. Number 1, research. We heard you loud and clear. You value our consumer research, and we are going to keep doing it. Priority number 2 is investing in collaborations in Massachusetts that fit one of 3 goals: those that increase the power of consumer voice in research, quality improvement, or program design; those that support clinicians and health systems in improving collaboration, connection, and communication with patients and communities; and lastly, collaborations that prepare patients to speak up in their clinical interactions or seek out clinicians that listen. And it's not by accident we're preparing patients at the end of this list, because part of this strategy is sort of recognizing that while patients want a voice, agency, and control, the very nature of our healthcare systems is often to strip them of that in ways big and small. Clinicians too often feel like cogs in the system themselves, but we must deal with the reality that we can only empower patients so much. So we're working on developing new collaborations, and we'll of course continue to support our existing ones. You'll hear a little bit more about that later in the show. And our last priority is really about supporting the field, all you here together in Massachusetts, bringing us together, providing resources, webinars, opportunities to champion your work, connect the dots across our state. So here is the whole plan all together. These elements are inseparable from each other, and together will guide our work in the next 3 years. You can download it on the link to the left or right. I'm left, right challenged. So thank you all for your contributions to the coalition of these last many years. We could not have done any of this without you, and you are all critical to the path forward.